One of the big advancements in orthopedic medicine or interventional orthopedic medicine for patients with neuropathic pain or nerve pain has been the development of neurofascial hydrodissection. It's not uncommon for people to have pelvic girdle pain syndromes. There are a myriad or a multitude of different nerves that exit from the pelvis and go into the groin and the saddle area or down the leg or into the buttock. And this may be from some previous procedure, it may be scar from surgery. And today we have the ability to be able to visualize these nerves under ultrasound, look at them very clearly, track a needle tip right down to the very surface of the nerve, and then with a simple medication we can inject and lift the connective tissue up off that nerve, and then once it starts to be lifted using volume of fluid. So you're injecting and it lifts with fluid, lifts the tissue off the nerve, and then you just advance the needle without touching the nerve, just staying right on its surface. You have to know what you're doing. And as you hydrodissect, you just continue to advance and you just peel the adhesions and tissue away from the nerve. That has a soothing effect to the nerve. The particular medication that we use for that is unique, dampens neuropathic pain, restores the membrane potential of the nerve, and so many patients with neuropathic pain are getting better that we never could fix before. I used to send all my patients with ulnar nerve compressions to the surgeon and have releases done. Today, it's a rare occurrence that I have to send a patient. With ultrasound today, we don't make the misdiagnosis of, oh, this is an epicondylitis. We can examine the epicondyle and say, hey, your tendon's totally normal. Let's flip over here and look and see if this nerve is, oh yeah, let's hydrodissect this deep branch of the radial nerve. And we drop in and we hydrodissect that nerve, and all of a sudden that ache goes away in the elbow. It was a nerve entrapment. If the nerve pain or the compression or the damage to the nerve internally from compression stays there long enough, nerve pain becomes neuropathic. And neuropathic can then cause shooting pains, it can cause burning pain, you can end up with skin sensitivity. Let me share a perfect example. A patient just gets out of the operating room for a meniscus procedure with my partner. And so he does the meniscus surgery, everything goes well, no problem, but she gets out of the car when she's home and she falls and she breaks her tibia the day of surgery. So then she has to be evaluated again, she has to go through immobilization to have the fracture heal, and everything is is gone awry. When the cast is removed and now we're really looking at this patient, she's having severe pain radiating down the inside of her leg all the way to the inside of the foot. She can't touch her skin, she can't put clothes on her skin, she can't let the water from the shower strike her skin without it hurting. She has this shooting pain that's there all day long. So she was originally diagnosed as having CRPS, complex regional pain syndrome. She wasn't referred to me till a year later. So a year later, I was requested to do a sympathetic nerve block, which is a more complex procedure than a simple peripheral block. And when I looked at her, I noticed that it was following a peripheral nerve pain pattern. This was following a nerve pattern. It wasn't following it wasn't this autonomic phenomenon that we see from the other disease. This was very specific, a saphenous nerve. Well, the saphenous nerve runs right next to the tibia, which is where it was fractured. And under ultrasound, as we looked at that, we saw that the saphenous nerve was encased in a little area of hypoechoic tissue, which was probably scar or organized hematoma or whatever. And all we did was take the ultrasound, track along the saphenous nerve, and hydrodissect that nerve out through that tissue. And in one single visit, with about $5 worth of medication, she's never had a reoccurrence. So a year later, we intervened, and even then we were able to bring that back. That's an example of neurofascial hydrodissection used by orthopedic practitioners with advanced ultrasound skills.